Welcome to this WFNR seminar on neuroethical problems. Today, welcome to all of you wherever you are in the world and what time of the day it is. For WFNR, ethical issues are becoming more and more important. We have a lot of ethical issues to deal with. It's the availability of resources, the division of resources. It is the eventual ethical restraints of technology coming up more and more. I just mentioned artificial intelligence, for instance, and possible threats to human autonomy and things like that. So ethical problems in whatever we do are very important and have to be addressed properly. I'm very grateful to this special interest group on neuroethics and neurophilosophy to take care of this. And today we will allude to some important aspects of neuroethics in neurorehabilitation. Let me also express my gratitude to our friends in Romania, Christian and Raul, who always help us in a very nice and generous way to broadcast these webinars. And I think I give the mic to Heinrich, who will introduce the outline of today's webinar.
Thank you, Volker. I only can repeat that the enormous progress in the field of neuroengineering inevitably has an impact on neurorehabilitation, and new opportunities are opening up. But at the same time, the ethical challenges in neurorehabilitation and neuroscientific technologies such as neurorobotics and brain-computer interfaces concern the preservation of human dignity, autonomy, and privacy of patients. It is about how such technologies can be used responsibly to maximize the benefits while minimizing the possible risks and negative effects on the individual. And that will be the topic of today's webinar. Now, not to lose time, let us start with one of my co-chairmen, Giorgio Sandrini, who will introduce our first speaker. Please, Giorgio.
Thank you. I am really pleased to introduce the first speaker, which is Professor Sabat Vasti. He is a co-chairman in World Federation for Rehabilitation Special Interest Group of Neurophilosophy and Ethics. As you know, very recently the two special interest group of neurophilosophy and neuroethics and ethics have been merged into one group. I think that this fact is very positive, since ethics and neuroethics are fundamental paths of the philosophy today. His talk is concerning in particular the relevance of ethics problems in neurorehabilitation. Please, Sabat.
Thank you very much, Giorgio, for that kind introduction. Allow me, Christian, to share my screen, please. Okay, for some reason, let me go back. Start. Okay, so there we are. I will put that up there. All right. So thank you very much. It's a great pleasure to be part of this very important webinar. And what I will do is to just give a sort of not very long, but a introduction of ethics in context of neurorehabilitation and how I believe, or we believe, the practice of neurorehabilitation should incorporate ethics. So just with we are going no disclosures. It's an ethical talk, so I had to disclose that there were no disclosure pertaining to this talk. So what approach I will take is just to take you through a little bit of understanding of ethics. We have a varied audience, I presume, from across the world. So not every way may be aware of what ethics exactly means in different contexts from cultural context. So I'm going to take that through a little bit of a history of that, then talk about ethical principles, difference between day-to-day medical ethics and rehabilitation ethics. And this is where we're going to take a little bit of time to understand how a rehab team or a rehab practitioner should think in the context of their patient care when the ethical aspects arise, difficulty with implementing ethical principles, and then specific approach and focused approach around one particular group of patients that may actually be very relevant to what we will discuss later on in terms of neurobotics and AI and brain-computer interface. So the definition of ethics is sort of quite varied. Different people refer to it differently. So I thought I'll keep it simple. Ethics is a part of philosophy dealing with morality. So you do right by the people, you are ethical. If you do something wrong, you are unethical. And moral is a search for an inner standard that actually conforms to the rightfulness of a society. So those two things have to be borne in mind as a practitioner, that you are doing right for the patient, and that in the context of the societal and the cultural aspects of that person, you are actually morally right for making the morally right decisions for that particular person. So that takes us to Kant's categorical imperative, which says the individual shall act in a way that this action can be regarded as a general law. So law would only become when it is acceptable. You will not make a law that is not acceptable to people or is harmful to people. So Kant actually say the imperative is that you shall act in a way that can actually constitute a general law, which is in the interest of people. Brief history in the Western literature, it is widely accepted that the founders of ethics were the Greek great philosophers, Socrates, Plato, and Aristotle. And Greek philosophies are mainly based on the moral virtues. Values are natural rather than convention, and ethics is treated as a science. That naturally sort of was taken into a Christian thinking, and St. Augustinus or Thomas Aquinas then incorporated the Greek ethics within the Christian thinking and brought the spirituality into it, attainment of happiness, that when you do the right thing, you should spiritually feel sort of fulfilled, and that the God will be happier with you. And then the modern ethics evolved and against the background of such thinking. And there are several different branches of ethics now that people are practicing: value ethics, existentialistic ethics, American bioethics, which basically rules most of the healthcare ethics now, Marxistic ethics, and theological ethics. However, before all this was happening, there was a strong tradition of ethics that existed in ancient times in other societies. In India, for instance, Charaka clearly outlined 4 ethical principles for a doctor. He said the friendship towards the sick, sympathy towards the sick, interest in cases according to one's capability, and no attachment with the patient after his recovery. The Charaka Samhita emphasizes the values central to the nobility of this profession. Those who trade their medical skills for the personal livelihood can be considered as collecting a pile of dust, leaving aside the heap of real gold. Now, this is very relevant at the moment where we live, in the days we are living in, where the dollar bill is becoming so much more important in the way that we deliver the patient care. And maybe we'll have to go back to this ancient thinking and start doing something about that revenue, the contextualized revenue cycles. Furthermore, he also regarded kindness to humanity as his supreme religion and treats his patient accordingly, succeeds best in achieving his aims of in giving good life, and obtains the greatest pleasure in doing so. So the pleasure of a physician by treating a person is supreme to Charaka. Confucius, on the other side, in the Chinese sort of tradition, the reign is the Confucius virtue that denotes the good feeling, a virtuous human experience when being altruistic. So again, he emphasizes that the happiness that you extract by being good to your people and the way you treat them is supreme and is endowed by heaven, at the same time the means by which a man can act according to the principle of heaven. Yan Hui is another principle where Confucius' most outstanding student once asked his master to describe the rules of Ren, and Confucius replied, one should see nothing improper, hear nothing improper, say nothing improper, do nothing improper. So very simple and very straightforward, and you can incorporate that in your medical practice, particularly in the context of rehabilitation, because in many ways you have to be very careful of the patient's secrecy, patient's dignity, their family secrecies and their dignities. And that's why I think it is important to think in a Confucian manner when you're treating the patients. However, the first formal document on medical ethic was published by Ali al-Ruhawi, who wrote the book called Adab al-Tabib, a conduct of a physician. So this was the first treatise dedicated to medical ethics. He regarded physicians as guardians of souls and bodies and wrote 20 chapters on various topics related to medical ethics, which are still very pertinent: what the physician must avoid and beware of, the manners of the visitors, the care of remedies by the patient, the dignity of the medical profession, the examination of physicians, the removal of corruption from physicians. So this is very important. And very interestingly, the first documented description of a peer review process was found in the Ethics of the Physician by Ishaq ibn al-Ruhawi of Al-Raha, Syria, where the notes of a practicing Islamic physicians were reviewed by peers, and the physician could face a lawsuit from a maltreated patient in the reviews if the reviews were negative. So that was the first documented medical legal aspects, or a properly sort of reviewed medical legal aspect of a patient care. So Hippocratic Oath, we all are familiar with, that we all take when we become physician. There are three portions to it. I'm not going to dwell too much on this whole text, but I'll just tell you that there are three aspects in which the physician should hold the person who he learns the art of being a physician in high regard. And then he should actually exercise that art in a very noble manner, and we shall not do anything to harm a person. And then also, when he actually the third part is very important, and this is important in rehabilitation, that when you become intimate with a patient, you enter their homes, you become closer to them, you get to know about their inner houses and the functional of their families. You need to keep to be especially careful from abusing the bodies of the man or woman, or the bond or free, or their wealth. So this is the important component of Hippocratic, the three components of Hippocratic Oath. And there's an obligation to heal, not to do harm, not to do a procedure that one is not trained to do, not to administer lethal poison, not to carry out abortion, and protect patient and his or her family's secret. And these are the basic principle of our practice as well in day-to-day rehabilitation care. But the problem is that we have been overtaken by the revenue cycles and the money bits of the healthcare, which is very important, of course. We can't run a healthcare service on an open string. So, but at the same time, I mean, this cartoon just is a sort of tongue-in-cheek, stating that a 34% cut in our corporate ethics should return us to profitability. I personally believe that we can do it otherwise. We can be ethical and yet be able to run financially the healthcare service in a decent manner. But the problem is we don't know how many years of a non-disabled life is worth how many years of a disabled life. So we can't attach the value on a person. And this is where the rehabilitation ethics become very pertinent, that we have to make the lives of the people who survive with their impairments that lead to disability worth that of a non-disabled person. So in doing so, we need to adhere to the bioethical principles. Autonomy of the patient is important. Beneficence, the non-maleficence. So you allow the patient or their families to make the right decisions for themselves or guide them in making those decisions properly. You have to be beneficent, so you do no harm, sort of do the right thing by the patient, do the best thing for them. Non-maleficence, you do no harm. Now, the justice component of bioethics is very difficult, because this is where the rehabilitation falls down. We give somebody tons of therapy, and then another person we don't have time to provide that therapy for. We need to be just, and obviously build our trust with the patients who we treat. So, ethical and medical ethics is a word whistling, and in neurorehabilitation are different. Traditional medical ethics has largely developed in the context of acute and immediate care. The disease, so it is disease or condition focused. It's event or intervention specific and survival centered. So you need to, when a person comes to a hospital, the ethical aspects of their care actually are surrounded by what the disease is and how they have to be managed, what consents we have to take in order to do which intervention, and whether a person will survive, or do we need to talk about sort of allow natural death or do not resuscitate issues, or take their organs out for somebody else. So this is where the acute medical or medical ethics is mostly centered on. There are other issues, don't get me wrong, they extend their practice beyond this, but this is where the most pertinent issues people deal. In rehabilitation is a more protected engagement paradigm. You have a life and a living focused, so a person has to not just be alive, they have to have a fair and a good quality of life. So that is one issue. It needs to be process driven, so that you need to provide right kind of treatment throughout the care protocol of a person, and at what point which treatment is given in the first 2 months or first 3 months, and where do you take the patient to the next level, when do you ask the patient to return to driving, or when you allow a person to return to driving, when they can go back to work. So this is a little bit of more protected process, and it is obviously person-centered. It's not intervention-centered, it is not disease-centered, it's person-centered. So the rehabilitation ethics, therefore, has a different emphasis. So just to traditional medical ethics versus rehabilitation, just to expand on that, focus on person autonomy in rehabilitation rather than patient autonomy. Active treatment participation model, where the person can refuse physiotherapy on a day when they are sort of feeling fatigued, rather than passive treatment where a person cannot refuse antibiotic dose because they have to be given that. An educational or a process-based model of consent rather than a contractual or event-specific model. So you have to educate a person into what you are doing and why you're doing it, and how this process is going to evolve, and that consent has to be reviewed and renewed periodically. An intimate role for the family that can blur the distinction between the family and the patient, but without losing a person's role and decisional independence, if that is possible. There needs to be a greater honesty about quality of life judgment, not imposing extraneous values. So, for example, a person and an immigrant living in a alien society being rehabilitated, they have to be rehabilitated in the context of their culture, their religion, their style of life, not impose upon them the values and the systems that are prevalent in that society. More emphasis on personal values rather than clinical values. So this is what you need to keep in mind when you are delivering rehabilitation, particularly neurorehabilitation, where patient may have cognitive issues and disability imposed disability issues. Medical ethicists refer to case-based ethics as casuistry, and I believe that this is a good one to actually utilize when we are delivering rehabilitation. And I think this is an important one from the neurorehabilitation perspective. Casuists claim that the ethics is primarily a matter of attention to details or circumstances of the case. In order to launch and maintain the process of case-based ethics, rehabilitation service must become institutionally conscious and manage each case within the ethical framework. So we're talking about each case. We're not talking about a disease. So we don't have ethics for managing stroke. We have ethics for managing a patient with stroke, individual with stroke. through the course of their stroke life. And that those issues that we are actually attending to need to be pertinent to that case. All rehabilitation teams should acknowledge that each case has some ethical issues. In each case, the emphasis and considerations are largely around longer-term outlook, and final outcome and judgments are required to be made in the context of several months or a year or two down the line. So you have to be very, very alert to what might happen to this person at home, at work, and so on and so forth. So I'm just going to touch, because I don't have time to go into all the details of people with cognitive disorder, slight cognitive disorders, or people who lose their ability to mobilize. There are ethical issues in each one of them. Just to give you an example, a person who is a wheelchair dependent, who is unable to communicate, may not want to be taken out of the house on a given day, but because they cannot sort of express that, he's placed via hoist onto a chair and taken out. So unfortunately, I don't have time to go into all this, but I'm just going to focus very, very quickly on disorders of consciousness. In the case of persons with disorders of consciousness, the ethical issues become more pertinent and more challenging. There is 4 levels that we have to deal with: severe cognitive impairment, where a person is sort of totally disoriented, becomes maybe confused, not knowing where they are. Other than next level is maybe they are not able to respond at all. There is also a context of locked-in syndrome, which becomes very much more difficult, vegetative state, and coma. So ethical issues in rehabilitation of an individual with are surrounded by consent. So if you have to take, for example, a consent for peg insertion in a person with a disabled, you need to have a process. How do you arrive at that decision? If you have to have a tracheostomy tube to wean a person off, how do you arrive at this? So the consent issue is a big one. And even at the very simple things, not even interventional things, you have to, for example, start taking decisions on behalf of the patient for managing bank accounts or paying bills. How do you start doing that? How do you take a consent from a patient to sort of give permission or take permission somehow to be able to attend to his personal or close personal affairs? So this takes us to the issue of surrogate decision-making. We need to have a process of how that surrogate decision-making and how is a surrogate decision-maker appointed. There are emergency versus rehabilitation decisions. So if somebody has a cardiac arrest who is unable to express, do you resuscitate that patient or not? How do we make that decision? Rehabilitation decisions like, do you want to have a lift put into your home or not to take the person up and down, or do you want to move and live downstairs? We don't know that. There is a concern about neglect, patients who are maybe neglected within the society, within their homes, within hospitals, maybe left unattended for their essential needs. How do you set goals for these people? What goals to set? That is another major issue. And how do you determine the outcomes, rehabilitation outcomes? You say patient is improving, oh, this patient is ready to go out of the acute hospital into the long-term care. How do we decide that? So this is all very complex, and there is needs to be a institution-based agreements on how to handle these issues. We also have a very complex situation with the patients traveling, or the humans or people traveling across the world. We do come in our practice in United Arab Emirates with the people who are here underrepresented and cannot actually communicate or lose their conscious level to a level where they cannot be, their issues cannot be discussed with them. So such expatriates, immigrant workers, travelers, and refugees, we often see patients brought to the ED department with no accompanying relatives, often alone by the ambulance staff. With conditions such as neurological conditions, may not be able to provide consent or make any other decision due to disorder of consciousness. The emergent and life-saving decisions are made by the emergency and acute care staff, which is fine, that is okay, that has to be done. But life-enhancing decision and planning for life after, once they survive, who makes those decisions for them? This is a very complex one. We have developed a policy in our hospital, but I think most places do not attend to such issues in a systematic manner. I think that's one of the things that we have to do. So I'm not going to dwell too much. I hope I'm not running over time too much. Autonomy of the patient, not possible to exercise as patient has disorder of consciousness, and the decision-making cannot be extended to someone who knows him or her as he or she is not unrepresented. So I will leave you with this thinking that Benjamin Franklin advised his friend, the British scientist Joseph Priestley, to dwell over decision-making on a few days and put pros and cons on a paper as they come to his mind. And then after a couple of days or 2 days or 3 days, sit down and see how do the pros and cons balance, and then make a decision which should be a balanced decision. I suppose in such cases, in these underrepresented cases, we should have discussions over discussions and make a process that we can apply. This is just a tongue-in-cheek. Charles Darwin's pros and cons to marry versus not to get married. If anybody wants it for their own personal use, I can send this on. So surrogate decision-making, how should this be done? How is the surrogate decision maker appointed for such people? We need to develop a process for that. Who is appointed to do this? For how long does surrogate, how often should we check whether a person still requires a surrogate decision maker or not, and when to withdraw that setup if a person improves? For what matters such surrogacy is you have to provide, financial matters. Should it be the same surrogate for financial versus clinical decision making? So these things we have to discuss. We have to, as a group, Neurophilosophy SIG, for instance, and the ethics SIG together, we need to start thinking about these issues and start guiding our peers, our colleagues across the world, how to actually develop protocols for these difficult situations, and how should we place this structure in place. So there are legal issues. How is the legal representation made? Who decides in the best interest of these patients? This is a very common thing that we medical folks just become quite paternalistic in sometimes and say, this is the best interest of this patient, we should do this. But how do we come to that process of the best interest of this patient? We don't have that. It's just a sort of term plucked out of the thin air, but we don't have a protocol in the best interest of this patient, protocols or policies. How do we arrive at that decision? We need to be sure that a person does not have a living will or advance directives. And in a contextualized manner, we also have to define quality of life. We cannot decide for somebody else that this person's quality of life is going to be bad. Many people would like to live or be around for some reason which may feel very trivial to us. And I remember a patient who, an arteriopath, as I started training as a rehab doctor, who had a brainstem stroke, and my professor asked me to go and discuss with this person whether he would like to be resuscitated because there was a high chance of cardiac arrest happening. And he said, I want to see my water. I know I cannot walk and I cannot do anything else. I'm totally dependent, but I want to see my daughter go down the aisle when she gets married. So, different people have different aspiration to continue to breathe. And assisted suicide and euthanasia, we need to be very careful when we decide about this thing. Just European countries are passing laws about this. Assisted death, they call it. The UK Parliament has just passed the law. And the concern is that people can make decisions when they are not feeling so bright about themselves, may have a reactive depression, and there needs to be a clear process as to how you arrive at a position of making a decision that, yes, we will assist a person to end their life, his or her life. So ethical dilemmas that we have to deal with and we have to answer is discontinuation of life prolonging interventions on quality of life basis. How do we define those? Financial consideration in care provision, for example, discharge to a care facility rather than home because of high financial cost of care at home. discontinuation of rehabilitation on the basis of cost versus outcome. So if you think the outcome is not going to be that great, you discontinue the rehabilitation of a person because you will feel that you'll spend a lot of money for a very minimal outcome. Improvement or a minimal improvement. Who are we to decide about that? That is a difficult one. Non-availability of rehabilitation in certain parts of the world is a big issue. Informing agencies of patients' disability and capacity. This is another big problem that we often get the employers pushing us. Can a person return to work? Should we? Is he capable of working? And we need a process as to how to divulge very sort of medical information to the patient's employers, banks, and financial agencies, and other such areas, and dealing with the medical legal aspects of rehabilitation with respect to if a person was involved in a road traffic accident and has got a brain injury and that was his fault, how do we defend that person, or how do we deal with that? So these are all the issues that a rehabilitation team has to, particularly neurorehabilitation practice, has to deal with. So a final message that all rehabilitation teams should acknowledge that in each case there will be ethical issues. In each case, however, the ethical emphasis and considerations should be around longer-term outlook. Final outcome and judgments are required to be made in the context of several months or year or two down the line, and not based upon the outlook over the next few days and few weeks. Decisions require a broad-based experience and senior members of the team who should be responsible for making, reviewing, and implementing ethical decisions. And lastly, a delicate balance must be achieved between compromised individuals' personal autonomy and allowing it to be overridden. Thank you. Thank you very much.
Thank you very much, Sabahat. I'm looking on the screen, on the chat screen. There is no question concerning your presentation. So I would propose to make a general discussion at the end of our presentation. Yes?
Well, nevertheless, for the audience, you should use the question and answer option if you have any immediate questions, so that we collect that also for general discussion. For the panel concerning Sabahat's talk, are there any urgent questions or nasty comments?
Nasty will be
Sabahat?
No, I see no.
No, good.
So yes. Okay. Therefore, I will ask now Giorgio to introduce our second speaker, please.
Yes. I'm pleased to introduce the next speaker. This is Professor Marco Iosa of the University La Sapienza in Rome. He is the chief of the Laboratory for the Study of Mind and Action Rehabilitation Technologies, and he developed several relevant studies in the field of neurorobotics, including in particular in the last time the relevance of ethical aspects. Please, Marco.
Marco, where are you?
Marco?
No.
Here I am. Sorry, I'm having some connection problems.
No.
Okay. Now I'll start with my presentation. Okay, sorry for the connection problem. Okay, let me share the screen. Okay. Okay, thank you very much for this kind. And do you see the presentation, right?
Yes.
Okay, perfect. In 2012, we proposed a review about the most important devices for neurorehabilitation. It is more than 12 years ago, and the first one was the first device. Most important was a robot. We were right in proposing this kind of technology as one of the most promising in neurorehabilitation. It is important important to define what is a robot. The English word robot derived from the Robot Institute of America defined robot as a programmable, multifunctional manipulator designed to move material parts or specialized devices, for us, patient or patient limb, through variable programmed motions for the performance of variety of tasks. It's important to see that the robot is programmable, is adaptable, and can provide variable behavior in response to the situation and for us to the movement of patients. And there are very different kind of autonomous robot, those that are related obviously to the patient. In this presentation, I show some shadows of neurorobots for us. That we described in another review of 2016 that we call the three laws of neurorobotics, in which we try to show some criticism that are related also to ethical issues. First of all, as I said, the correct definition of what is a robot and the cost of robots. It is important also approach with rehabilitation, massive mobilization of patients' limb, and now is more focused on a top-down approach in which also cognitive aspects are involved. Isaac Asimov, the father of science fiction, in 1950 wrote these laws and used this, starting from these laws, to make a review of scientific literature, some aspects, some ethical issue to take into account when robots are used in neurorehabilitation. And we will see each of these laws step by step. The first law that we have rewritten was a robot for neurorehabilitation may not injure a patient or allow a patient to come to harm. It is quite obviously all the electromechanical devices, obviously especially for patients, obviously about a medical device. But what is important for us was to focus that we can consider harm also poor efficacy of a treatment is an harm for our patient. So we need some device that provide a high level of efficacy risk ratio. Neurorehabilitation is that they are very adaptable, very efficient for correctly a personalized medicine. But as Morasso and colleagues highlighted, it can lead to a paradox that they call the effectiveness paradox. A very personalizable device could allow to many different protocols that could be applied to each patient. But when we would test the efficacy of rehabilitation, for example, in a randomized controlled trial, we need to have a standardized protocol, very standardized program of rehabilitation. So the efficacy is dependent on the personalization, but at the same time, the generalizability of our results may depend on standardization of the protocol. There is also an important difference difference between neurorobots, for example, and pharmacological drugs. When we have analyzed the different important reviews about robots used in neurorehabilitation, we found these ideal features of neurorobot. They are mainly related to the fact that the movement could be very repeatable, very intense. The movement could be task-oriented, and just at the end, we can talk about efficacy. This is very different about the phase to put on the market a drug. As you know, it's important, it's fundamental for a drug to be tested, its efficacy, not just safety, on many, many patients. When we wrote this review in 2016, at least in Italy, a robot device could be put in the market just with the safety certification, but not with a sort of efficacy certification. So many studies were conducted by research group on robot devices that they acquired or they tested in their hospitals after the acquisition, after the robot was already on the market. And it was very particular, very different from pharmacological drugs. And now the Italian law changes a little. There is the need of at least a pilot study to put a robot on the market. Then many studies asked if a robot is effective, but more than 10 years ago, we proposed to change the question from are robot effective into who may benefit from robot. It's fundamental to the identification of the patient that could be could be the best candidate for robotic rehabilitation. For example, in this study, we showed as groups with low motricity, more severe stroke, for example, can benefit more from robotic rehabilitation with respect to less severely affected patient that could benefit from robotic rehabilitation at the same level as conventional rehabilitation. So it is important to the allocation of the resources, that is an ethical issue, the allocation of the resources for the correct patient that should be identified in to be trained, to be rehabilitated with these robots. For example, another and to the identification of the clinical features of patients. For example, in conventional therapy, we found that the most important prognostic factor are the severity at the beginning of at admission into the rehabilitation hospital and time from stroke at admission. Instead, from robotic rehabilitation, for example, of for lower limb, for gait, it's fundamental that patient could have a good control of the trunk. So also the prognostic factors are different between these two different kind of therapies. There is also another aspect related to the fact that robots are quite expensive, obviously, and we should be already Stephen Hawking talked about the problem of machines and robots in the that should not increase inequality. Robots could be used in a more rich hospitals, or even patients that, for example, I think to spinal cord injury patient that need an exoskeleton to walk also out of the hospital, should spend a lot of money to acquire a robot. And another aspect is that in some research projects, patients are trained with prototypes of robots, but after the research protocols, they did not continue this kind of rehabilitation. So some, for example, European project trained in the framework of European projects, patient with spinal cord injuries are trained with exoskeleton, but at the end of the project, we should say that was a prototype we cannot continue to use, even if it is a benefit for you, but we cannot continue to use this device. So we should take into account the fact that the robot should not increase the disparity in the services that health system could provide to our patient. But it could be a risk because these devices are very expensive. The second law of neurorobotics that we have rewritten was that a robot must obey to the orders given by the therapist, except where such orders would conflict with the first law. This is, you can say, this is obvious. The robot is a machine, so it just follow the order of the therapist, of the order of the human that set some variable. At the beginning, when robots entered into the hospital, therapists were scared to be replaced by robots. It is also what already happened in other fields of work in which machine they could lose their work. Robot is more intense, more reliable, with movement more standardizable, is task-oriented. It has many sensors that provide us information about the patients. But the therapist should be included into the loop of between neurorobot and patients. We cannot think that this relationship is just between patient and neurorobot, but the therapist is fundamental. And the therapist could select many different programs. And so it depends how the therapist is trained, how the therapist prefer to use the robot, and also the experience and the know-how of the therapist in using that robot. And there is this argument that I would to clarify. There is a very important difference, for example, in neurosurgery robots and robots for neurorehabilitation. In neurosurgery robots, it was very clear that the surgeon was empowered by using the robot. The vision with cameras are empowered, the precision of the movements, there is a scale system that make the movement more precise, is fundamental. So it was very clear for the surgeon that the robot could empower him. In our field of rehabilitation, it seems that it is not clear for the therapists how the robot can improve their abilities, but it's not a problem of the therapist. It's a problem of the how this robot related to the available technology. So in this loop is important also what the patient prefer. For example, other aspects related to that, you can see in this figure, it was our paper, there is written that the walking speed selector is not really a walking speed selector, but it was a cadence selector. So sometimes we think, therapists think to adjust a parameter in the robot, instead they are adjusting something else. Robot, for adjusting that parameter, should make some different decision that can it's not clear, it's not exactly related to the desired behavior. Another example is the body weight support. In these other studies, we showed as the patient group in black can reduce the energy consumption of walking when he's on the robot with different percentage of walking support. But it depends on what the therapist would like to do. For example, the therapist can decide to prefer a more expanding in terms of energy walking for the patient, a trainer with a higher level of energy required. It is not just for the robot related to lower limb, but also robot for upper limb, for example, the working volume of the robots moving the arm of the patients, we found that this working volume is not strictly related to the clinical parameters of the patients. So the increase that we can observe in the working volume of robotic rehabilitation is not strictly related to an improvement of the efficacy of the robot. So what we are measuring when we observe an improvement of working volume. So maybe there is a problem in which we could say the patient improve the use of the robot, but we need that the patient improve his mobility, his ability in other fields. The translationality of the benefits obtained on the robot in real life is an ethical issue that is important. Furthermore, the working volume, the movements that we perform with the robot are three-dimensional, but usually the robot include a screen with the task that usually based on video games that are bidimensional. So it can limit this transferability in real life. Then there is a very complex relation between patient and robot, as I show you in these schemas. What is an output from the robot is an input from the patient, and what is an output from the movement of the patient is an input for the robot. Furthermore, there are a lot of feedback that the patient could be receive, and the patient could be the feedback could be positive when the movement is correctly executed, or negative when there is an error. Could be a binary error yes or error no, could be continuous, could be visual, acoustic, and many other kind of feedback, biofeedback, or even neurofeedback during robotic rehabilitation. It implies an important aspect about cognitive involvement in neurorobotics. For example, we found that many patients with anxiety don't like to be trained with robots, and they ask to they drop out from robotic protocols. So, how we should consider this patient? The dropout. Moreover, we should consider this patient as a good candidate or not for neurorobotics. So the identification of the best candidate should take into account also cognitive aspects of our patients. These cognitive aspects are well taken into account in a study of Aprile and colleagues that showed us as different device for upper limb robotic rehabilitation improved some cognitive aspects like episodic memory, calculation, and reduction of unilateral spatial neglect. But probably not just for the robot, but just because the robot include video games and specific tasks that the patient should understand and should execute. The third law, that we have written for neurorobotics, transparent manner, as long as this doesn't conflict with the first and second law. So in this complex relation, robots, as I said, is unadaptable and sometimes is automatically adapted to the behavior of the patient. This automatized behavior of the patient should lead the robot to make some decision about the parameters. For example, the percentage of assistance as needed, the percentage of the guidance forces, or other parameters such as the increase of walking speed or the step length should be accomplished by the robot in a clear manner. It is not always like that. For example, the guidance force, that is a parameter very important for that the therapist can adjust during robot use. That is, it is how much the robot move the the limb of the patient strictly related to a specific trajectory. When we talk about trajectory, we are talking about something that is related to space, is something related to the kinematics. So we talk about guidance force that seems something about related to dynamics, to kinetics of the robot. Instead, the therapist should know that guidance force is more related to the kinematics. It is not so clear in the use of the robots. And when the robot has a behavior not so clear, there is an ethical issue. So with the introduction of artificial intelligence in robotics, there is more emphasized this problem, because artificial intelligence makes some decision in an autonomous way. Even the programmers doesn't know exactly what happened. Even the bioengineers doesn't know, because they don't develop a exact program to say to the robot how to work. But with artificial intelligence, especially with machine learning, especially with deep learning, in which there are many hidden layers, know how to work, how to learn to be effective. But then we don't know what the robot will learn or will apply what he learned during the experience with many patients. So the loop, with the pencil inside, should include therapists, medical doctors, bioengineers, and robot. Probably, but now artificial intelligence is in the circle of bioengineers, but then there will be probably an independent circle in this loop. It's important to identify the right robot for the right patient at the right moment of his rehabilitation pathway. So we proposed that the ideal hospital should have different devices and should select the patient to be trained with different devices at different level of the rehabilitation, both for lower limb and also in this other slide for their upper limb. Obviously, it is quite difficult. As I said, another problem is the cost, as I already said, and the use of this robot in these are prototypes, or they are commercialized in different hospitals, in different centers. In Italy, we have worked on the consensus conference called Cicerone about robot-assisted rehabilitation. So it is fundamental to have an agreement about to use robots that involve the different profiles, as I say, therapists, medical doctors, bioengineers, but patients also in this important aspect. For example, many papers have been published after this consensus conference. I would suggest you this one, written by Morone and colleagues, that is an important systematic review for identification of the guidelines in using robotic in rehabilitation. So my conclusion are that it's important that robots are not only safe but also effective, but the focus should be on patients' needs about efficacy, not just on technology. Sometimes we say, bioengineer could say that we have this technology and we can apply to the patient, but we should start from the patient needs and then find the correct technology that could be more effective to match the patient needs. Then the adaptability of the robot is needed to be human-driven and controlled by humans in a clear manner. Finally, this loop, therapist, patient, robots, bioengineering, should be clear, should be very clear, the differences and the aspects for all these people involved in this loop. Just I conclude showing you this funny drawing of Altan that say the patient with a very sophisticated technology, but he said, dumb technology, now I must go somewhere. It's fundamental that we start from patient needs and then take to out in all our ethical aspects the attention. Thank you. Okay.
Thank you very much, Marco, for this very extensive presentation of robotics and all the connecting issues. Any questions from the audience? No, I cannot.
Let me, Hannes, if I may,
Oh, yes.
let me make a short comment, because
Yes, please.
Marco has, at the end of his talk, also alluded to that. And I think that is extremely important. For the further development of these technologies, we definitely need a better interaction between bioengineers, clinicians, therapists, patients. You know, I know the field is expanding dramatically. You know, from meeting to meeting, you see more companies going into this field and creating new robots for upper lower extremity and whatever have you. But at the end, we are still lacking a concept framework, how to blend these robots into a useful therapeutic regimen. And I think that can only be solved if the interaction right from the beginning, when a new robotic device is going to be designed, is considered. And you need a very, very tight interaction between the clinicians and the engineers. The engineers are very happy if they have good technology, and they're more than proud to spread this, of course. But this is not always helpful. And the discourses and the languages of therapists and bioengineers are not always identical. And we have to work a little bit in this direction. I think that's very important. We are stressing that for 20 years, but nevertheless, it's difficult to achieve it. Do you want to comment on this, Marco?
Just that I perfectly agree with you. It's fundamental to have a multidisciplinary team, but I would suggest also the need of have multidisciplinary people, in which we are also the therapists should be intrigued by some bioengineering aspects and medical doctor by medical aspects. So it's fundamental for me that are try to understand the different needs of the other professional figures.
Yeah, well, we are claiming that for a long time. The problem is how to bring that into real life. You know, so into the real life of development of these devices. We have to keep that in mind. There were several questions, but I think we leave them to the end from the question and answer section. We are sorry sometimes the transmission doesn't work perfectly, so there may be gaps. There was one question, I may answer that right away. This is available soon, within a couple of days, 8 to 9 days, also on the website of WFNR, so you can reread that if you want. Good. Go ahead.
Okay, thank you, Volker, for your more or less short comments. Let us, if no further questions, and I cannot see any question on the chat screen, we can continue. And I ask newly Giorgio to introduce our last lecturer.
Thank you.
I hope he's available.
Yeah,
he's there. Yeah, I see him.
Okay. Yeah. Okay. Suryo, hello.
Hello, Suryo. I am really pleased to introduce Suryo Sokadar. He's a professor of clinical neurotechnology in the Department of Psychiatry and Psychotherapy in the Neuroscience Research Center in the University of Berlin. His research covers very large areas of neuroscience. In particular, several studies are concerning the relationship between engineering and clinical science. Please, Suryo.
It's a great pleasure to be here and to see all the friendly and known faces. I will try to give you an overview about the ethical considerations about brain-computer interface, and that's a dynamic area. So there might be always coming up new considerations, but I try to at least catch most of them. So before we go into the ethical considerations, I would like to give you an update about the field. So as you all know, brain-computer interfaces, the link between the machine and the brain is an old dream of mankind. And as long as computers exist, there was the idea to connect the brain directly to the machines. And that was mainly a part of science fiction. And there were a few exotic groups, like the group of Niels Bierbaumer, who tried to implement that for completely paralyzed patients, but it always remained an exotic application until maybe 2016, 17, when Mark Zuckerberg and Elon Musk invested hundreds of millions of US dollars into this technology. And now, after a few years, this whole field of brain-computer interfaces is becoming mainstream. So that was also the reason why, when I was asked to explain what will be the medicine of the future in the German television show called Charité, they clearly picked up the idea that neurotechnology will be an essential part of medical treatments, and also go beyond active control of machines, but it would also make the brains readable by the machines and allow, for example, paradigms like bidirectional brain-computer interfaces and brain stimulation. And well, this is very good proof that this is now mainstream, because it was shown in the German TV every evening at 8 p.m. and millions of people watched it and did not complain. So they were in tune with the idea that neurotechnology will play a very important role in the future medicine. So just at the beginning of October, a new study from Morgan Stanley came out, and they estimate that the market for brain-computer interfaces in the US alone will sum up to $400 billion US dollars. So that is a number that is really, really, really high. And if we look closer into it, we will see there is some in neurology, in the medical field, but there's a lot in psychiatry. And I'm going to also talk about these applications a little bit, because they might raise more ethical questions than those that you probably all know in the neurological domain, where it's about restoration of movement. So, as I mentioned, Niels Bierbaumer was one of the pioneers to establish brain-computer interfaces, active BCIs, to assist a patient with severe paralysis to select letters on the screen. And in parallel, there was the development of brain-computer interfaces for the restoration of movement. And this field was mainly dominated by invasive approaches. And that is mainly driven in the US. But China is also now really investing a lot to reach the same level. And I would say in many fields, they also have a Neuralink device, very similar to what Elon Musk is doing, or the Utah array. So they are really building these devices. They're not publishing much about it, but they are establishing this technology in China. So this is what you probably all know from the media. The latest implant of Neuralink. It's inductively charged, and it is implanted by a machine, a robot, which with highest precision implants little electrode threads into the superficial layers of the cortex. And you can implant approximately 1,000 electrodes. And with this, obviously, it's possible to control a cursor. And these are the first applications of this new device in patients who are dependent on assistance in daily life. So this patient here, for example, who can only play chess with a stick in his mouth, and now he was implanted with a Neuralink link device. And you can see here the procedure. And immediately after the implantation, he was able to control the cursor, and there's nothing new about it. Now, this has been now linked to computer games, and you can see how happy he is. And he was very open to explain what it actually gave to him. So obviously, he had much more abilities in everyday life to command the computer. And in the beginning, he was really playing computer until 2 a.m. in the morning. So he used the device for 6 to 8 hours, playing different games. And then after it came out, that he was actually developing an addiction to playing these games, he gave interviews where he emphasized that he's also learning Japanese with this device. But it was very clear that the message here was also this kind of assistive devices can also be addictive. And another problem came up because after 6 weeks after implantation, some of the threads, they got loose. They got disconnected from the brain tissue, approximately 85% of the device. And that left him unable to control the computer anymore. And of course, he was very depressed for a few days until the engineers figured out how to use the rest, the 15% rest of the device to control a cursor. So he's still using the system, but this very first patient already showed what kind of impact this kind of technology can have for a patient. Not only in a good way, obviously. So this is another example now here from Europe. This is Onward, and they you all know them probably, but I wanted to create the context for the discussion. So they are focusing on spinal cord injuries, and here they are collaborating with another company, developing epidural brain-computer interfaces, and the patients have to imagine to walk, and then you have machine learning algorithms decoding that and then stimulating the spinal cord to initiate gait movements. And what you can see, he always has to look down. He has to see where is the foot, because he has no sensory input from his legs. And of course, I'm now emphasizing all these aspects that are usually not emphasized in other, I would say, presentations. So I was able to talk with patients who were treated in Geneva, in Lausanne, and well, some patients, they really said, well, when they got offered, they had the spinal cord stimulation, but they got offered to take the next step and get an implantation into their brains, and they declined, and they said, well, I don't think that this is the right choice for me because there's an increased risk, and actually what I can do is quite limited. So I have other problems than walking and always having to look down to my feet. I can take the wheelchair and just take the same distance in just a quarter of the time. So this also shows that maybe some of these demonstrations, focus on certain functions, but other functions that might be more important for the patients are actually not discussed. So another device here is the Synchron electrode, developed from in Australia, but now mainly used also in the US. This is an intravascular electrode, like a stent, which records intracranial EEG. And with this, you can also command a cursor, for example, and do clicks. And of course, you can control an exoskeleton with this, but very low degrees of freedom. But still, you have another way to communicate with a machine. And the risk is relatively low. So, as I mentioned, there are a lot of risks involved with the implantation. And in many cases, if you have a malfunction, the repair also requires another surgery. And as you can see here on the pictures, it can affect the brain in different ways. So usually you have microbleedings, you have gliosis, And usually over the years, the signal quality is decreasing. So still you can use the electric signals for cursor control, but the level of control, the bandwidth, is decreasing over time. So that's why we have developed these non-invasive brain-computer interfaces. And here you see the quadriplegic patients who are unable to grasp these different objects, and like a pen or a cup. And we have equipped those patients with an exoskeleton and an EEG cap. And with an EEG cap, they can do essentially the same. So a very simple approach, but very powerful approach, because now these patients can grasp and manipulate these different objects of daily life. And of course, they could also use it outside of the laboratory because they had this cap on. But over the last years, we have worked to improve the design of these systems. That was just the very first demonstration that you can restore autonomy in these quadriplegic patients with very simple means, and it's all non-invasive. And here you see the patient who was able to feed himself with the potato chips. And you can also see here how happy he is that he's able to do this where he always needed support. Now, we have used this system in chronic stroke patients, sometimes decades after the stroke. And you can see they usually, when they attempt to move the paralyzed fingers, they activate the whole central region. And after the BCI training, after 1 month of BCI training, when they used it on a daily basis for maybe 40 minutes, we could observe that some of the patients could move the fingers again, even after decades of paralysis. And what we've seen in the MRI is that there was a relateralization, and that correlated with motor improvement. So the BCI was not only used as an assistive device, but as a restorative or rehabilitation device, as a training device. And that, for me personally, is a much more plausible application for scaling up brain-computer interfaces in the medical field than implanting electrodes into the cortex. So now this is a demonstration of the latest, I would say, state-of-the-art in wearable exoskeletons in stroke. So you can see the patient with the exoskeleton can do these bimanual tasks, activities of daily life, much, much faster. And you see it's all without any cables, without any constraints. They have to wear the cap. But everything is very lightweight, and you can actually establish this within a few minutes. So you can actually really implement this already in the clinical workflow. And of course, that is something that has a lot of potential, especially for patients who have no finger movement. So you would use it in the beginning to restore EMG, discernible EMG activation. And then from there, you would go to an EMG-driven exoskeleton and then maybe constraint-induced movement therapy. So there is this pipeline. And if that motor recovery is not triggered, you could use exoskeletons with brain control for assistance, just to avoid learned non-use of the whole arm. So that's our idea, and we are working on it to establish this in the hospital. It's a long way because we have to get the certification, we have to get more data about the clinical efficacy, but that's what we are trying to do now. Now I summarize the state of the art. So I've introduced the brain-computer interface in the medical field for improving autonomy. And the important message is also that the repeated use of these brain-computer interfaces can trigger plasticity and neurological, but maybe also cognitive and affective recovery. So that is something that was mentioned before. So the question here is, of course, if we have this powerful technology, of course, there is a right to have access to it. There's Article 9 of the UN Convention on the Rights of Persons with Disabilities. So that is something that, of course, has to be considered if we are developing these new technologies, that we also have to make sure that there is access to it. And as I mentioned, there is no reason to think that these training devices can only be used in the motor domain. So essentially, you could also use this in the cognitive domain or in the affective domain. So just as a short spotlight here, this is a patient with chronic depression, Sarah. She had undergone ECT, all kinds of psychotherapy, more than 20 medications, and she had still severe suicidality and severe depression. And she said that the emotions were unbearable, and that was the reason to include her in a study where they implanted in Stanford 10 electrodes or 10 electrode strips, recording from deep areas in the brain. And she had to press a button whenever she was feeling these overwhelming emotions in the darkness. And after 1 week, they found that there are certain areas in the brain that are very specifically active when she's pressing the button, especially in the amygdala. And then they tested where to stimulate the brain to suppress this activation in the amygdala. And they found several possibilities to achieve that, but it was always dependent on the brain state. And there were some areas like the ventral striatum, which when you stimulate, effectively suppress the activation in the amygdala. So that was the rationale to implant 2 electrodes, one in the ventral striatum and one in the amygdala. And whenever in the amygdala there was too much activity in the gamma range, they would stimulate for just 2 or 3 seconds the ventral striatum to suppress the amygdala activation. And what was happening is that after 1 week, she was doing much better. The suicidal thoughts were disappearing, and she reported that the lens through which she was seeing the world has changed. So it shows that these kind of brain-computer interfaces, closed-loop neuromodulation devices, they can be also applied in the psychiatric domain. And now the question is, okay, where is all this going? So we, of course, would like to do this non-invasively, because implantation is not an option for psychiatrists really on scale. If you think that maybe 20% of patients are of the population develops a depression, and then there are these severe cases, and then the success rate is also not guaranteed because it depends where to stimulate. So ideally you would do this non-invasively, but the problem is shown here. So if you use electric stimulation or magnetic stimulation, you are essentially stimulating half of the brain and mainly the superficial layers. And now, of course, that has to be somehow changed, and that's also the reason why we have developed new stimulation techniques. And what is even more important is that while you stimulate, you should be able to record from the brain, and it's also something that technologically can be solved. So here we show that it's possible to stimulate the brain while you record electric activity or neuromagnetic activity, and do this in real time. So you could establish a closed loop system with this kind of approach. And we have established this successfully with EEG and with electric stimulation. And we have shown that you can, for example, improve or suppress cognitive function, for example, working memory that's dependent on the phase of the stimulation. So you can really modulate these different domains in the brain. And it's possible now, but what we need is something that stimulates deeper into the brain, and that's why we've developed this new temporal interference magnetic stimulation. You don't need to implant. You can do this very precise, and there is a flexible targeting and no sensory confound, which is very, very important because in the non-invasive domain, you have lots of placebo effects, you can imagine, because you can feel that you are stimulated. So if you have a means to do a placebo control, something where there's no sensory confound, of course, that would improve the situation scientifically, looking into the specific effects of stimulation tremendously. So this is where we are, and of course, the EEG is not the final end solution for brain-computer interfaces. So the EEG actually is actually very bad for brain-computer interfaces because you can only record the slow oscillations in the brain, and there's no real spatial resolution. You can maybe discern the frontal from the central region, but in real time, it's very difficult to do source reconstruction, spatial filtering, and recording from higher frequencies. And that's the reason why we are now increasingly adopting quantum sensors into the brain-computer interfaces, because these sensors, they are sensitive for other frequency bands, and they provide much higher spatial resolution because the magnetic fields are just passing through the bone. And in the future, of course, we want to combine the quantum sensors and the temporal interference magnetic stimulation and develop a non-invasive approach for this kind of brain state dependent stimulation in the frontal lobe, for example. So that is just an overview of what we are doing and where the field is. And now, of course, all these technologies, they raise a number of ethical questions, and they always center around the dimensions of privacy, of autonomy, the question of consent, the question of equity and access, and of course, unintended consequences, unanticipated consequences. And of course, that has to be addressed. And now the OECD has established a working group since 2019 on these questions. And there's also the UNESCO increasingly interested in the ethics of neurotechnology. So they also have a recommendation now. And something that was, I would say, gaining more traction in the ethical debate was some very concrete cases where patients got implanted with some stimulators, and then the suppliers and the companies went bankrupt. And then there was no one to really ask if there's something wrong with the machine or with the device. And that draw a lot of attention into this kind of challenge, that if billions of dollars are invested into startups developing implantable technologies, the question is now, okay, what if something has been implanted and the companies go bankrupt? And that will happen with very high probability in the next years, to a level where it becomes a problem. So let's go through the different areas that are relevant for the ethical considerations in brain-computer interface. So the first is very obvious: privacy and data security. So if data is recorded, and it's very similar to anything else that you also wear, for example, the Aura ring or something where you record physiological signals, the question is, what can you infer from it? And of course, there is the idea that if you record from the brain, there is more information, maybe more information that can be inferred from these signals than from other physiological signals. And then, of course, there is the risk of data breaches and this idea of brain hacking. But in the end, the question is, how likely is it? But since this is really a severe problem, it has to be considered and included in the regulation. And this is done to a large degree, also within the context of the medical device regulation, for example, or the FDA. So they have this in their regulation. Then, of course, there is the field of autonomy and cognitive manipulation. So I have already mentioned that if you have a bidirectional BCI, where there's also a stimulation part, it becomes challenging to really say what has been coming from the stimulation, from the BCI, from the technology, and what was coming from the biological system. Yeah. So then there is this problem of undue influence. So the systems can, of course, modulate neural activity. Right now, this is mainly done in epilepsy, for example, to suppress epileptic seizures. But theoretically, this could be extended to any other brain state that is undesirable. So, for example, impulsivity or some cognitive capacities can be influenced here. And then, of course, people would say, well, yeah, it's clear an epileptic seizure is a health risk. But it's only a question of time when other brain states are decodable and is eventually also can be also modulated. Now, I have mentioned before, so if you implant something into a patient, the question is then, how does this alter the person's sense of self? So there were cases where people got an implant and then they gained some ability, and then there was a malfunction and they couldn't really continue with what they regarded as their self and their function. And then they said that was like a second trauma. So they lost their identity, and that is an issue. Also, for example, a case where epileptic seizures were very reliably suppressed, and then the system didn't work, and the patient would say, now I'm isolating myself, I'm not leaving the house anymore, and it has a very severe impact on my personality, because before I was more going out, meeting friends, and now I don't do it anymore. So it can cause a lot of psychological distress. And what I also mentioned before, with this one patient who started to play until 2 a.m. or 3 a.m. in the morning with the games, is that it may introduce dependence, and affect the reward system, which if you link it to certain softwares on the smartphone, they are programmed to create addiction. And usually you have distraction from your daily life, your wife is calling you and so on. But if you are a patient who is very reliant on this kind of machine interaction, and cannot do much more right now than to interact with a computer and with a smartphone, then the risk of developing these kind of addictions is, of course, increased. And finally, there is also the risk of social stigmatization. Right now, this is not really so much the case. So people would say, well, they apply for example, these studies because they want to be cyborgs. They want to, be augmented. But if you could also turn it around and say, well, maybe in the future people might face stigma because they are augmented, or they are using this kind of technology. So this whole dimension of informed consent plays, of course, always a role when it comes to interventions that have consequences for a long term. So the question of complexity of understanding, but also the dynamic effects of once you have the neurotechnology applied, it, of course, may over time have unintended side effects. As I mentioned, dependency or altered personality. And now the question is, okay, what can we do? Right now, there is this idea that we should not fall into the same trap as with the social media and say, the main idea is to connect everybody with everybody, and it has only positive effects. This is something where people say, well, we don't want to do this again. We want to anticipate the social effects, which is very difficult to really do. But that is the reason why the OECD has developed this framework of, I would say, soft law to protect the citizens. But the question is then, okay, is that actually something that is powerful enough? Because right now you can see all the discussion about enforcement. So even if someone has been has a verdict by the International Criminal Court, the question is, what is the consequence? How do you enforce it? And there's, of course, some kind of a prisoner's dilemma, because if there's no enforcement, and if you really want to do something that is technically possible, there is always some place where this will be done. But still, the UNESCO and the OECD are trying to influence the national governments with soft law, and there is an ongoing process right now in the OECD countries to adopt the recommendations of the OECD into their laws, national laws. And of course, there are initiatives like this one where people are calling for global standards for consumer neurotechnologies, because to some degree the ethical impact in the medical field is somehow quite well regulated right now. But the idea that this will go beyond the medical field is, of course, very present, and that's a question of national security to a large degree, and there is no regulation for it. So right now, if you say, well, this is not a medical tool, it's a lifestyle tool, and then it doesn't fall under the medical device regulation in many cases, except if it's brain stimulation. Then the new regulation already includes that, but there is essentially no regulation for consumer neurotechnology, and that's why we are trying to raise awareness of what may come as an ethical consequence of these new technologies. That's the end of the talk, and I'm happy to discuss.
Yes, Surya, thank you very much for this very impressive talk. I've heard you the last time in Lyon. It's the same the impression I have gotten from you. Thank you very much. Now, if I look at the chat screen, I see there are 7 to 8 questions. Can you see all these questions also or not? Have it on your screen?
Oh yes, now I can see them.
Yes. Yeah, I think the first questions are related to nursing and caring. How robotics and these new techniques can support nursing care, and yes,
I think this question was actually for my predecessor.
Yes, exactly. So I have to ask Marco. Yes,
Marco.
Marco,
yes. And well, at the moment the robots are mainly for using therapists, but there are starting some robots, for example, for drug administration in the hospital, but they are still prototypes that are used to be with patients during the day and to remember them to take some drugs. It is more for to be with patients that to help nurses. And at the same time, probably with the arrival of artificial intelligence, there will be more robots that virtual robots also, like chatbot, that could help medical doctors, for example, in the identification of the diagnosis, obviously never substituting the humans, but just to be an help for them.
Yes, I think this is the main point. It's not instead of the nursing peoples using the robotics. This is true. Yes.
Well, we have a lack of nursing personnel everywhere. And of course, robotic devices might be helpful. We have some limited experience in that.
But not instead, yes.
No, but not instead, but they may augment the work.
Yeah.
And help them as distribution of medications, entertaining patients or asking patients the questionnaires and things like that. The major problem is that these robots cannot open doors, right? So they cannot open the door of the patient's room, right? That limits that to some extent. But
I would say not yet. Let's see.
Not yet. No, that is solvable, of course. But well, I think it's not a bad idea to have human-friendly robots helping with nursing problems, and that will certainly be developed soon.
Yeah. There is a very relevant problem when the humanoid robot replace the nurse or medical doctor in the communication. For instance, using ChatGPT. Since there was a very famous case some years ago in which a human robot communicated to a patient that his disease was very, very severe. It's you have just a few hours to live. This is terrible. But I think this is very relevant from ethical point of view. Otherwise, I think that robot humanoid is it could be useful to help, not to replace, to help nurse and the medical doctor.
Yeah, the let's say artificial intelligence going with that can be very helpful when it's restricted to simple things, right? It can be disastrous when it comes to the organization of complex problems. And of course, that has to be sorted out.
Yeah.
If a humanoid robot approaches a patient and says, "Good morning," and "How are you?" and "Can I do anything for you?" and like that, that's fine. Okay. When we have problems with that, we are running at the moment, WFNR is running a big project on an AI supported avatar system where a patient or a relative can approach the system and ask, my father has a stroke and whatever, and what can I do? That can, as an educational tool, be very helpful. Nevertheless, it has to be ascertained that what the avatar, driven by an artificial intelligence system, tells the people is valid and reasonable. And if we do it in a restricted way, I think it can be done. But of course, that's absolutely right. One has to be careful when it comes to more complex problems that may give rise to additional ethical questions about the reliability of this. That's a reliability problem, right, and a knowledge problem at the end of the day. But I think nevertheless we have to play with this in some sense, and we have to sort out what can be done. I give you an historical example in history of medicine when Edward Jenner many years ago started this inoculation business with smallpox and cowpox. It was an 8-year-old boy who was the son of his gardener, who was let's say, the guy in whom it was tried out. And when we use ethical standards as we use them today, we would probably never have found it. And so we have to really sort out the risk versus the possible benefit. And that is, of course, also true for also the human augmentation business in implants and so forth. It's very much the same problem. We have to delineate between what is a possible harmful thing, how this can be prevented, and what is a possible useful thing coming out of it. And we cannot agree with it. And that is an empirical problem. It's not only an empirical problem, but it's also an empirical problem.
Okay, thank you, Volker. Now coming to the next questions, I think the next 2 or 3 questions are for Suryo. Does neurotechnology have any application in neurodiversity? I don't understand what this means, but the last
autism, ADHS.
Yeah, what are the considerations addressed considering brain disorders of consciousness?
Yes. So, well, neurodiversity. So, I guess it's about autism spectrum and ADHS, and of course, yes. So the answer is yes. There's a long history of neurofeedback in ADHS, for example, and certainly these technologies will improve. And there are a lot of startups actually in the US going exactly into this direction. But the question in the end is, what is the efficacy? And you need a very good, well-controlled studies, and that's on the way, I would say. So there is a role. The second question is disorders of consciousness. So that is something that Niels Bierbaumer was really working on many decades. And yeah, the first consideration that he was always pushing was that if there is a tool that allows you to communicate and you have the care, and you, for example, have a degenerative disorder which ends up in locked in, people would vote for artificial respiration, and the quality of life would then be actually comparable to anybody else. So it's about the communication and the availability of these tools, which may influence the decision of being artificially respirated or not. And that is one component. The other component is, of course, the care component. So if you feel that you are a burden for your environment, for your family, and so on, you certainly will say, I rather don't want to go this way. So these are the considerations. And I would say, well, there is a lot of people who, beyond the application of locked in, also look into pseudo coma and other, fields where related to disorders of consciousness. And well, the neurotechnology can at least tell you whether someone is awake or not, or whether there is actually some complexity in the brain processes or not. And that, of course, can be very helpful for the people around. That they say, okay, the person is awake, you can talk to the patient now, or you could even use a BCI and make these people communicate. But usually, that's my experience, since they don't have any advocates, and Niels Boerbaumer is out of business, I would say now he's retired. There is not a lot of research going on anymore. So this is now something where, we do business as usual. Yeah. So, but of course, there's this clinical need. And
I
then
think the query might have been whether you can wake people up with the stimulation.
That has been shown, with ultrasound. There are different studies.
Right, that's right.
With brain stimulation, ultrasound, even with deep brain stimulation, there were some studies with thalamic stimulation. So that is, I would say, in the exploratory
So the
stage.
ethical aspect of that would be that a person who is in a deeper state of unresponsiveness, and we bring that person out into a kind of semi-deeper state of unresponsiveness, whereby he was unaware of his predicament before, and pain and the difficulty that he had. Now we have made that person aware of his disability, his level of difficulties, and all the rest, and then we can't get him any better than that. So have we emotionally caused trauma to that person from bringing him out of a deeper state into a lighter state, but not any better? That is the ethical aspect. So we don't have the answer to that as yet. And if we don't do it, we can't get people better. But if we do it, it's just a between the devil and the deep blue sea issue. But I don't know what the right answer to that. But that is the real query that burdens me. That if we do get people out of their deeper state of unconsciousness into lighter state of unconsciousness, are we actually exposing them to more emotional trauma?
Yes, it's a very, very good question. And I would say, well, it is also comparable to the question of whether you want to have excessive technological support. If something like that happens, and people should be thinking about it and make a choice and say, okay, in that situation, do you want to go to the maximum, go for the implantation? And that's essentially also what Niels Boerbaumer did with some of the ALS patients. And he asked them, okay, once you reach the complete locked in, would you want me to implant? And some of the patients, they said yes. Yeah, but this kind of conversation has to be done before, you are in the state, because then you can't make these choices anymore. And that is something where I would say, it's important to anticipate these kind of scenarios and find out for yourself, would you want, and what would you do then? Yeah. Because you would also need to ask the patients about end-of-life decisions, and it's another discussion, whether you can do this with this kind of technology, and whether you should do it.
But locked-in patients certainly are different from those with really
they are different
of consciousness. That's a completely different issue. And what Sabat raised, I think, is a very important point. You don't know if you do anything good if you wake them up.
Yes.
And they cannot decide if they want to be waken up or not. And that, of course, is, I think, probably an unsolvable ethical
decide.
issue.
No.
But if you don't try it, you won't get any progress.
No, right.
And that on the meta level is again an ethical problem. Should we not exploit everything which is eventually possible and may at the end of the day be useful? Right? So do it on the individual level or on the social or general level. You will come up with very different answers to that.
There is one question regarding the assisted dying. What are your thoughts regarding the bill? I don't know whom of you can talk about this.
I think this refers to the UK Parliament bill that has just been passed, I think about 3 days back, on assisted dying. And I don't know the ins and outs of that bill. This was very heavily debated in the Parliament. The reason I refer to it is because in neurological patients, it's difficult to work out whether with people with chronic disability they fluctuate. I have people with spinal cord injury, high cervical cord injury, and one day they say that, well, I don't want to live anymore, and then you see them a week or two later and they're happy as Larry. Things are good, yeah, I'm fine. So this fluctuant basis, that's why I referred that ethically from a neuro rehab point of view, what processes do we have to put in place to have a person decide whether they would wish to have their life ended? And I think as these things become more relevant, particularly in cases of ALS and other such cases, locked-in syndrome, we at sort of World Federation level, we need to discuss this in the neurophilosophy and ethics sake, whether we require a set of guidelines for the practitioners, for the rehab teams, that this is what you have to do. You have to assess a person for X, Y, and Z, mood disturbance, fluctuation of their mood, fluctuation of their decision making, and you have to observe them for over such and such time before you make a decision in this respect, or help the person make a decision in this respect. So it's a very tough one, and it becomes even more tougher when somebody else makes a decision on the patient's behalf, who is unresponsive, who cannot consent to anything, and his wife or his father or brother say, well, I would rather you switch the you give him switching the ventilator off is a kind of easier side, but if the person I would rather you help him to just pass out quietly because he's suffering too much. So these are the discussions and these are the debates we have to have in our federation, and then go out to people to give some sort of guidelines as to how they need to handle these situations.
Thank you very much. The last question, very interesting, is the ethical concern for computer spammers to mess up with the implanted brain chips. So it's your turn.
Drag the account details out of patient's brain, the bank account details.
Yeah, but in fact, it is, well, there are these active BCIs, and then there are these passive BCIs that are just monitoring your reactions, your physiological states. And of course, if you depend on that kind of interface, I'm sure that this could be a national threat. And that's the reason why our Agency for Cybersecurity is investing exactly into this question, because you will have billions of users, not only a few patients, but that is then threatening every citizen if they are using this kind of interface on a daily life basis. But it's not a medical field anymore.
Okay. No further questions? No?
Let me make a comment on what Suryo said. I think there's one thing which is very important, and we definitely need more work. And someone mentioned multi-center studies in the chat room as well, for these very simple EEG-based exoskeleton BCIs, which are without any significant risk, anything, which, however, can be extremely helpful for two reasons. One, helping people for bimanual interaction with a severe, let's say, impairment of the upper extremity on one side. And the second one, what Suri also mentioned, is that they may open a chance to rewire the brain by using this type of activity, which is very harmless, really, and does not really generate ethical questions on the first glance, but nevertheless will be extremely helpful. We worked on this for some years now, and nevertheless, we do not get progress on this. To install that as a general, easy to handle tool, which might eventually help 10,000s of people easily.
Okay, Volker, thank you very much for this comment. We are absolutely in time. And so I come to the conclusion. To conclude what's from my point of view has been the main points of the webinar today. I will start with Sabahat Basti. He spoke about the different aspects of acute medicine and rehabilitation. In the first case, for instance, it's the question of sickness from the point of the patient and the diagnosis of disease from the view of the medical doctor. In the case of rehabilitation, the main point is the return to the society and the prevention of ableism and promotion of inclusion of the patients. He also spoke of the concept of morality and ethics in different cultures. This is, from my point of view, very important, which, for example, the Western term have only just adopted. Also comparable content also exists for a long time in other cultures like India and China. And he pointed out that it is about the best interest of the patients, especially in the case of disorders of consciousness, what we have to respect. And finally, we also have the contradictions between our ethical ideas and business interests of various groups. Has to be very careful seen. The next was Marco Loza. He spoke about robotics and all related areas. Now, there's no doubt that robotics represents a revolution in rehabilitation. However, it should not be forgotten, and this was also pointed out, that it can only be used individually, and that people, as the determining element, continue to make the final decision, at least for the time being. Volker, I think you also made additional comments straight away concerning all these. And at last, Suri Sudhakar spoke about brain-computer interfaces. And brain-computer interfaces are, for me, the counter-evidence of gradualism. It is a revolution, and we do not know where it will lead us after listening to Suri's lecture. You all read a lot about brain-computer interfaces in the media, like science fiction and so on. But here it was shown very impressively what is currently possible. Even it is only applicable to selected cases. And of course, the technology must also be available and affordable. One small comment that worries me is a possible development towards transhumanism, which I personally do not like very, very much. Not at least Surya also stressed many ethical questions concerning autonomy, identity, cognitive manipulation, and so on. I think this is for the future very important to respect. This, from my point of view, the main topics we have raised during this webinar. I will thank you all participants and for all lecturers. It was for me a very important, very impressive webinar. Thank you very much.
Thank you.
Thank you.
If I may say a closing word concerning the future WFNR strategy in this. I think we have learned a lot in this respect also today. And what we did not discuss is the universality of such thinking. And I think there are easy to communicate universal standards for this. And I think what WFNR should probably do to come to at least a minimal set of universal standards for the ethical problems raised, disorders of consciousness, brain-computer interfaces, and all this. And we will work on this. The webinar today gave me some more motivation again to go into this direction. Thank you.
Thank you.
Thank you.
Thank you very much and have a nice day.
Thank you.
Thank you.
Thank
Bye.
you very much.
Bye.
Bye-bye. Take care.
Bye-bye.